Okay, Vidushi, I think we're ready.
Hi, everyone. I'm Vidushi Sood, one of the endocrinologists at UW. And our endocrinology fellow, Dr. Neha Bapat, will be talking about a patient we saw together last month. Uh, she is a first-year fellow at UW-Madison. She joined us. She did her medical school in India and then her residency in Baltimore. So Neha, you can go ahead and present.
Thank you, Dr. Sood. Can you see it in like the slideshow view?
Yeah.
Okay, perfect. Yeah, so our patient is a 75-year-old female who was seen by us for evaluation of her bone health. Her relevant past medical history was that she was diagnosed with estrogen and progesterone positive, HER2 negative, HER2 negative left breast cancer. This was diagnosed in 2008. She was treated with lumpectomy and axillary lymph node dissection, followed by dose-dense chemotherapy. She was subsequently on tamoxifen between 2008 and 2010. Unfortunately, had recurrence in 2010 and lumpectomy again, followed by radiation. Subsequently was on anastrozole, and then she switched to letrozole in 2012, was on it until sometime in 2016. Wasn't entirely clear because not all her care was with us, but it was sometime in 2016 that she stopped letrozole. She also had history of mucoid epidermoid carcinoma of the retromolar trigone on the left. This was treated with surgery and adjuvant radiation therapy in 1993. Unfortunately, she developed osteonecrosis of the jaw, and this required a free flap microvascular tissue transfer or to reconstruct her left mandible using a fibula. And this was in September 2015. Going over her bone densities. So as you can see, from 2012 onwards to 2024, especially from 2016 to 2024, there was a significant decline in her bone density at both the spine and hip. In that DEXA, which was done in 2024, her FRAX showed a risk of major osteoporotic fracture 20.3%, and the risk of a fracture at the hip was 8.3%. And that, of course, all of this combined was concerning. She fortunately didn't have any history of fractures as an adult, but there was a reported history of frequent falls, and she'd been dealing with some balance issues on that front. She didn't have any history of like prior medications for bone health. And during our visit, we also noted malnutrition. She wasn't really taking in too much calcium. And so in an effort to optimize, just diet and lifestyle measures, we discussed those, discussed optimizing calcium intake. Also recommended that she meet physical therapy given her history of frequent falls. This is her blood work, which is unremarkable for the most part. Her PTH was 66, 25 hydroxyvitamin D levels were 37.6. Yeah, that's sort of the most of it was unremarkable for us. To summarize, this was a 75-year-old female with past medical history of breast cancer and mucoid epidermoid carcinoma, which was treated with radiation and unfortunately complicated with osteoradionecrosis of the jaw, presenting with progressive decline in her bone density and an increased fracture risk with a history of frequent falls. So especially concerning. And of course, we wanted to treat her. And our question is, what would be the best treatment option in such a patient who is noted to have a progressive decline in bone density with prior history of osteonecrosis of jaw and radiation treatment? So I'll start with just the incidence of osteonecrosis of jaw, and more relevant in our case would be patients who've, been diagnosed with oral cavity cancer. and subsequently received radiation therapy. So this study looked at 936 newly diagnosed patients who received radiation therapy from 2000 to 2013. The median follow-up was 55 months for the survivors, and the overall incidence of osteonecrosis of the jaw was 13.7%. 13.7% includes all three grades of osteonecrosis of the jaw. The American Association of Oral and Maxillofacial Surgeons grades osteonecrosis of the jaw into three separate grades. So grade 1 is when you have exposed bone and no symptoms. Grade 2 is when you have exposed bone and symptoms, and then grade 3 is exposed bone symptoms combined with maybe a fistula formation or a pathological fracture, and more serious evidence of infection. So in this particular study, what they noted was grade 1 and grade 2 accounted for 3.4 and 4.3% of the cases, and then 6.1% patients developed grade 3 complication, and they needed surgical intervention or hyperbaric oxygen treatment. And of note, our patient needed to be treated for her osteonecrosis of the jaw as well. So she also had grade 3 osteonecrosis. Now, why this is especially concerning in this context is because medications that we use to treat osteoporosis also carry a risk of osteonecrosis of the jaw. Medication-related osteonecrosis of the jaw, there's different risk factors. High dose and or prolonged use of anti-resorptive agents, of course, is associated with it. Chemotherapy, corticosteroid therapy, and or treatment with anti-angiogenic agents. All of these are risk factors. More relevant to us are medications which are used to treat osteoporosis. So in these different classes of medications, for bisphosphonates, the percentage of or the incidence of osteonecrosis of jaw ranges from 0.02 to 0.05%. This includes IV and oral. With denosumab, there's a larger range from 0.04 to 0.3%, and romosozumab or Evenity carries an incidence of 0.03 to 0.05%. So very, very low risk. And overall, I will say a low risk. Between these three agents, at least looks like maybe denosumab slightly higher, but in the grand scheme of things is still low. Moving on to why osteonecrosis of jaw and osteosarcoma, both of these are sort of concern here. So this is the Forteo label. This is the most recent updated label from July 2024. So this has a warning and precaution, which states osteosarcoma. And as you can see, it says to avoid use in patients with increased risk of osteosarcoma, which includes patients with open epiphysis, metabolic bone disease, bone mets, prior external beam or implant radiation therapy involving the skeleton, and hereditary disorders predisposing to osteosarcoma. Radiation therapy independently of itself has an increased risk or carries a risk of osteosarcoma. And so the label mentions that, you should be using caution if a patient has history of radiation therapy, which our patient did. Now, the risk of osteosarcoma in PTH and PTHRP analogs, where does this come from? We see, just like we saw, the FDA label has a warning that it carries. Both teriparatide and abaloparatide have this warning, both Forteo and Tymlos. This warning, however, stems from studies in animals. When teriparatide was administered to rats at very high doses over extended periods, that resulted in an increased incidence of osteosarcoma. No incidence was noted in the fracture prevention trial. And a similar warning for abaloparatide is also based on studies in rats. No incidence was noted in the active trial or the active extension study. Post-marketing surveillance study has also shown no increase in osteosarcoma incidence with teriparatide. And the FDA removed the box warning for teriparatide in November 2020 and for abaloparatide in December 2021. I'd like to say here that for abaloparatide or Tymlos, we don't have post-marketing surveillance. I didn't find any study which looked at a larger over many years what the incidence of osteosarcoma is, but the post-marketing surveillance study that looked at patients who were on teriparatide was over 15 years. And so this brings me to possible treatment strategies for our patient. With everything that I went over with the post-marketing surveillance, do we truly think that there is concern of osteosarcoma with Forteo? One of the possible strategies we could adopt in her was is giving her Forteo followed by IV zoledronic acid. Is there any concern that the duration of Forteo treatment needs to be modified in this situation if we are, going to be considering this risk of osteosarcoma? We were thinking of Forteo followed by IV zoledronic acid because our patient is going to be unable to tolerate any oral bisphosphonates because of dysphagia. She unfortunately carries a lot of side effects from that radiation treatment as well. And I will say here that increasingly we've been seeing patients like this who have received radiation treatment and have gone on to develop osteoporosis. And one of the reasons we can't use anabolic therapy with PTH and PTHRP analogs is this concern that we have with osteosarcoma. If we are concerned, another strategy that we've seen adopted is cyclic Forteo or cyclic teriparatide. Studies that have looked at cyclic versus daily treatment have actually found that there is no bone density, no BMD advantage with daily therapy. The study that I looked at, and this was done over a 4-year time period, did not comment on the fracture risk, but it did say that there was no advantage on no BMD advantage. And of course, Evenity or romosozumab also remains an option, given that it carries a lower risk of osteonecrosis of the jaw. And in the event that we were to use Evenity, of course, we would also have to follow it up with an anti-resorptive agents. But we really wanted to open this up for discussion and especially with, are we really truly concerned with osteosarcoma, and is Forteo followed by IV zoledronic acid something that most people would agree could be a possible treatment strategy for this patient?
Thank you. That was terrific. So that was really great, a great review. So I have a comment, and I don't know how other people feel about it. So I'm pretty confident that teriparatide and abaloparatide probably don't increase the risk of osteosarcoma in the patients that have been studied. But patients with external beam radiation are not very many in those population data. So that it may not be true that that safety applies to people who've had radiation. I don't know. I don't know if anyone else has any insight into that question.
Yeah, we were trying to find that, and we were not able to find the subgroup analysis of, or at least I was not able to find the subgroup analysis of patients who have already had radiation therapy given Forteo. And we just saw yesterday a patient with breast cancer who had received external beam radiation, who went on to have some kind of a spindle sarcoma of the chest wall, like of the bone of the chest wall. And I think the radiation therapy inherently increases the risk of these cancers. The problem with our patient is that she has received radiation therapy and also has had grade 3 osteonecrosis of jaw.
Yeah.
And since 2010, I mean, she has had progressive bone loss. And if you look at the bone loss between 2016 to 2024, it was like 24% in hip. And we were really sure that she has hypoparathyroidism, but her PTH came back fine. So she has ONJ, she has this radiation therapy, and we just wanted to open it to the group to see, should we do Romo for 6 months, do 1 dose of CA, Forteo for 6 months or a year, do 1 dose of CA. I definitely don't want to do Prolia because I don't have an exit strategy at all. Like just maybe 1 dose of CA kind of. So just to open it up to see if anybody else has had this kind of an experience. I think Julia had mentioned.
So can I just ask a couple
Where was her
questions?
radiation again?
Her radiation was in 2016. Neha, could you just look back again? I forget the exact timing.
But
It was,
she's on
What
an
did they
aromatase
radiate?
inhibitor.
what's that?
Go ahead, Neil.
What did they radiate?
I
Her
think she
jaw.
had.
So
Did she have
yes,
radiation for breast cancer also?
Yeah, so she had radiation for breast cancer also, and then for the
Yeah.
epithelial cancer of the jaw. So, and that led to the osteoradionecrosis.
So I think that's relevant in that what disease does this person have? Does she have medication related ONJ, or does she have radiation related osteonecrosis of the jaw?
It was radiation related, ONJ.
Right.
Yeah.
And so that's maybe not necessarily the same thing.
Mm-hmm.
And so, if she's got simply radiation-induced jaw necrosis, then maybe we need somebody, and I don't know that we have this person in Wisconsin. Do we have an oral surgeon who is an expert in radiation-induced osteonecrosis? And I understand that our oral surgery colleagues have got, in essence, high resolution CT of the jaw. Does this person have evidence of impending radiation-induced ONJ? And, should she have one of these high-end cool jaw CT scans to say she is or is not at risk? And Joe, I don't know. I don't think we've got anybody in Madison who I would view as a expert in differentiating um, radiation-induced versus MRONJ.
Well, she's not been on a medicine.
Yeah. It's not been
But she
Yeah.
has definitely osteonecrosis already. It's not
Yeah.
like, so
But but MRONJ and radiation-induced ONJ, I don't think they're the same
I
cat.
agree.
I
I
think
agree,
they,
but I would not, but I think the radiation would make me nervous about using a drug. I think Vidushi and I are probably on the same page with this. It makes me nervous about
I
using it. Can I ask one other question? Is she on an aromatase inhibitor?
Not anymore. So
Okay.
she was on an aromatase inhibitor, and I think it was stopped in 2016 when there was
Okay.
all that bone loss that happened between 2012 to 2016. And the radiation osteonecrosis happened in 2015 or 16. She was treated for that. The problem is that she had had such extensive surgery that she can hardly open her mouth. I mean, like we were convinced that she's going to have severely low vitamin D because she's pretty malnourished. And I think she is not going to be able to. I mean, I'm just afraid of the oral hygiene. She hardly eats much. I mean, we basically spent all our time trying to optimize her nutrition at that time. And these falls are recent. And we actually also check B12, folate, just to make sure that we don't have anything else that we can do to prevent
So
falls.
can I ask one other
Yeah,
question? Could we give her tamoxifen?
Tamoxifen now.
I mean,
Or
I
or
thought,
a vis or a raloxifene. Yeah.
yeah, I
I
mean,
mean,
Mm.
uh,
yeah, something along those lines.
along those lines. So the reason I say tamoxifen is because she's not at risk for hormone positive breast cancer. She has it. So, many people treat them indefinitely with some form or another. So that would be one consideration. If I were going to treat her, I share your concern. I would be really concerned with a person who can't get good oral hygiene and has had
Mhm.
radiation necrosis. I certainly would never touch her with denosumab, not in a
No.
million years. Um,
Yeah.
if I were comfortable about the cancer thing, which I'm not sure I am, I would, if I were comfortable with teriparatide, I'd probably give her the 3 month off and on thing for 4 years, and then give her as little anti-resorptor as necessary for as short as possible. But
Yeah, I
I
actually
don't know
had
if that
a
makes sense.
I had a patient who literally, it sounds like the same patient. She had her first cancer was this this oral cancer. She had radiation. She had surgery for that. Then she developed a lung cancer. Shortly thereafter, he had radiation for both. Had osteoradionecrosis of the jaw. Had extensive surgery. Can't get good PO intake. Has terrible, dentition. They can't get in there to do any of her teeth work. So I really am kind of stuck with medication options. So I had her start Forteo. I talked with one of her docs that helped treat her cancer, her oral cancer, just to kind of make sure everything was in, remission as far as we know. There was no concerns for active cancer. She wasn't getting actively surveilled. Her cancer was around the same time as your patient as well. And after that, I talked with the patient. I talked about risks. I made sure she didn't have any active cancer concerns. She actually had a potential concern for Paget's disease of the breast. So we actually had her get a mammogram and all of that stuff prior. And now we're having issues with her tolerating Forteo, unfortunately. So now we're going to try Timlos. But yeah, I'm doing cyclic. I don't know how she's going to tolerate Timlos. That's been the biggest factor limiting actually for her. But we did talk about the risks of ONJ versus this possible osteosarcoma, and she kind of was in agreement that she'd rather at least try this option. She'd already sustained a compression fracture as well. So it sounds like the exact same circumstance as your patient.
So you're doing cyclic because you feel that the risk of osteosarcoma would be less in cyclic versus continuous. Is that the rationale there?
The rationale for me was to give her more coverage over time. My patient, I think, is in her late 70s. So my hope is to just use 4 years, space it out, give her maybe 18 months off, consider retreating her, because I don't know if I feel comfortable following it with ZA at this point. With her, her bad dentition, we can't get her a dental exam with the ONJ. And she's also very scared of the ONJ part. That was actually the thing that really was scary for her after we discussed the risks.
Does anyone know how many cases of ONJ have been reported with Romo?
The first trial, I believe, had one in both groups, right? One with Romo and one with the placebo group.
That was the number that I was thinking, Vidushi.
Yeah.
It's an N of 1.
Yeah, it was N of 1. And when, that is the one that I remember too. But if you look at the package insert, it clearly says ONJ. And my other thought was to do Romo as the anabolic part for 6 months and follow with 1 dose of ZA. I mean, I think that if I use a short-term anabolic, I will have to follow with ZA just to maintain a little bit. And that is the only option. I mean, if I want to have a long-term control, because I mean, I had not thought of tamoxifen. I think part of me, because it was the hip that was really bad, there was a 24% decrease in hip BMD over 6 years, 22 or 24. I don't remember the exact number. So I felt that the hip fracture, I was kind of very worried when I saw her with all the falls.
You're so far out in the weeds with this patient. The package insert is a mile behind us.
I know.
I would think about giving 3 months of Romo and doing that cyclically.
So 3 months on Romo and 3 months off Romo kind of a thing?
Yeah, and maybe even trying to, if you want to use a mild anti-resorber, using tamoxifen in the 3 months off, but there are zero data on that. But why are we worried about ONJ with Romo? I assume it's because of its anti-resorptive.
Anti-resorptive. That's what I was also thinking, that to do maybe I was thinking of 6 months of Romo.
There's no right answer, obviously.
I think you should present these options to the patient.
Yeah.
And there is no good option. I have been using the 3 month off and 3 month on more, like in people with AFFs who have osteoporosis, particularly if they're really old. If they're 89, and I can get them what I believe to be fracture protection regimen for 4 years. By that time, they're 93. Either me or they will be dead. So I don't have to worry about it. But anyway, I don't know. Yeah, I don't have Yeah, and I wonder about that Romo thing with the ONJ, but it is on the label.
It is on the label, yeah.
Neil, can I ask a question to you about your paper titled something like Denosumab rarely causes ONJ? But if you then looked at that paper and looked at the patients who had an invasive dental procedure, it wasn't 1 in 1,000 to 1 in 10,000 like I've been telling patients. It was about 1 in 150.
Right.
So I'd like to know why you titled the paper that way. I'm joking. I know you didn't title it. I just know you were on it, but
Yeah, I mean, I think, Joe, the gist of that data set that I saw for that paper was that despite the fact that these people got ONJ, continuing DMAB didn't cause their jaw to fall off. I mean, these lesions healed.
yes.
Um,
In a
I,
median of 11 months.
yeah, I mean, I agree. I wouldn't touch this patient with DMAB with a 20-foot pole. Um, uh, I think in this patient, I would consider short-term cyclic Romo, but that's why I prefaced my prior comments that you're so far off the package insert that you can't even see it in the rearview mirror.
So there's two questions. Somebody's asking if I've used cyclic Romo, and the answer is I haven't. But Neil, you can comment on it because you apparently have.
Yes, we've used it a lot, and it appears to work. And at some point in time, we'll get around to reporting a case series. But the gist of it is that with 6 months, we get at least close to the BMD effect that we get at a year if you use it for 12 months.
But Neil,
And that's consistent with the data, right? And if you look at the bone formation markers with 6 months.
Yeah, I mean, the bone formation markers with Romo are basically back to normal, back to baseline at 6 months. The anabolic effect is largely gone at 6 months.
so the data that you had presented previously, Neil, was that you did Romo for 6 months, then Prolia for 6 months, and went back on Romo for 6 months, right?
Correct.
So have you done Romo with nothing in between and then Romo again, like Romo for 3 months, nothing for 3 months, Romo again?
No.
No.
And
Okay.
unfortunately, Amgen is not interested in the type of things that you just laid out.
So Jin Chen is asking, would you use markers to manage this patient, bone turnover markers?
I didn't really do the bone turnover markers in her when I just saw her last month, and the reason was that I was convinced that her PTH was going to be high, but I was going to do the bone turnover markers. Although, even if the CTX is through the roof high, I don't think I would still give her an anti-resorptive. So I'm not sure that it will add too much to my decision making. I think I'm kind of almost committed to an anabolic, at least initially at this point. And the question is which anabolic I'm going to use.
Vidushi, what disease are we treating here? Are we treating bone loss or are we treating fracture?
We are not treating fracture. Thankfully, she's not had a fracture. It is bone loss and increased fracture risk and her history of falls. I mean,
And her history of falls. So how high is her fracture risk?
a MOF, like major osteoporotic was 20.3 and hip was 8, right, Neha?
Oh, so it's high.
Yes, it was it.
Yeah, it
So,
was
so one
because
thing, Neil, you mentioned that I think I'd be cautious about, if you're going to use tamoxifen, I don't think I'd give it intermittently because I'd either just give it continuously with the therapy or with the anabolic and not intermittently. There's all kinds of on-off stuff with breast
ABC.
cancer and stuff like that with hormones and anti-hormones. Plus the risk of VTE is highest at
yeah,
initiation.
Yeah.
So each time you restart it, you're
Yeah.
increasing the risk of blood clot.
yeah.
So
She's
if you're going to
7.3.
use it, I'd just
Tamoxifen,
use it.
tamoxifen has endometrial agonist activity. So, I mean, I
Yeah.
don't see why we would use tamoxifen over since
Over
bone is our
raloxifene.
prior thing. Raloxifene, she doesn't need another cancer, and tamoxifen does increase the risk of endometrial cancer.
Right, it does. The only reason why I said that is at least I know some oncologists who will not allow raloxifene in people who already have breast cancer because that's not been studied in that setting to my knowledge.
But
Whereas tamoxifen has been shown to reduce the recurrence in
yeah,
people with hormone positive breast cancer. Raloxifene has been shown to decrease the incidence of breast cancer in women at high risk. So I would definitely clear it with the medical oncologist
yeah,
before
for sure.
giving raloxifene to anyone with established breast cancer.
With an MOF of 20, does she really need a bone drug?
It's probably not counting her fall. I mean, we know it's not counting her falls. I think they're increased
Yeah.
concern because of her fall
I
pattern.
think also, like, I'm just worried that when I repeat the bone density next year, it's going to be lower and her MOF will be higher. I mean, I can wait it out and wait for the bone density to decrease further. And I'm pretty sure that's going to happen.
Her rate of
Yeah.
bone loss is huge.
Her rate of-
20% in
Yeah. And
20% in 8 years, was it?
Yeah, 20%, 22% in hip in 8 years. It was huge.
And what's her age? And how much of that is estrogen depletion?
I think she was
75.
75, yeah.
Yeah.
So it
So-
shouldn't be E2 depletion.
And her
And
bone loss continued after letrozole
after
was
stopping the
discontinued.
AI.
Yeah,
Yeah.
yeah. So,
You know,
yeah.
a real wise physician said, do no harm.
Yeah.
Yeah,
But
I
she
mean,
also has a hip fracture risk of 8%.
8.3, yeah,
Yeah.
yeah.
How
And
old did you say she was again?
75.
Okay. Yeah, I wonder if the malnutrition is going to be what kills her.
Her albumin, like her labs were better than what she looked actually. Her albumin was, I was, when we saw her, like we were convinced that everything will be really bad, but her albumin is better. I mean, her albumin is totally normal. Her creatinine is fine. Her vitamin D is fine. Her PTH is fine. Her alk phos is fine. I mean, initially I thought it's osteomalacia, but it's not osteomalacia. It is osteoporosis. I mean, couldn't find any other cause. She has had an aspect that was normal. Everything was normal. Her, celiac panel was normal. Everything else was normal.
Vidushi, I think the conclusion is nobody knows what to do.
But you can say you presented it at a conference, and here were the 6 options we came up with, none of which are good. But, yeah.
Yeah.
I mean, maybe Neil's point is well taken. Maybe you don't treat her until she fractures. Is
And
that kind of what you're saying, Neil?
Yeah, I mean, we've had all these reasons not to give this woman drugs. What can we do to keep her from falling over?
we have referred her to PT, and I believe that, that was like a very, very strong recommendation that was given to her as well as her husband and her physician, because her husband is a primary caretaker at this point who had come with her.
Yeah, and Kristen, I see, has a question in the chat. How much weight has she lost? Has she lost a bunch of weight?
Her weight was low. I think her BMI was definitely less than 19, but she has not had progressive weight loss at this point. Her
So
weight
we can't blame her hip decline on weight loss.
no, no, no. And part of me had thought that, should I repeat the DEXA in 1 year? I just feel like I just know that she is losing bone after stopping letrozole. And I think she's going to continue to lose bone. And I'm not sure then if giving her anabolic is going to, allow me to give her a break. I don't know. I just worry about not treating her at this point. But that's
I
definitely
think I probably would kick the can down the road and not do anything right now and have her prove to me that she's continuing to lose, but I can't tell you that that's right.
I mean, I can definitely give her that option also. No, this is most helpful. I will, I told her that I will present and talk to her after the bone club, so I'll do that.
Okay, I think we're done. Diane, do you want to have any closing comments?
Just want to thank everybody for signing on and staying on. And as I noted, these are recorded and they're going to be put up on our YouTube channel. If you want to refer people or go take a look at them, they should be up in 2 or 3 weeks. And hope to see everybody in April.